Welcome. I don't know about the rest of you, but here in Central Houston, it's rainy and stormy. And so we are thrilled to be doing something that takes our mind off of the weather. But this is also, we're closing out Mental Health Awareness Month. And so this is a great opportunity, although we should be talking about it all the time, not just during the month of May, but we should be talking about the mental health issues that come along with Parkinson's. Um, Specifically today, anxiety and depression, which your presenter is going to talk about. But this is an opportunity. This is our Community Partners Presents program, and it's an opportunity for you all to get more information just about daily, information on things that pertain to your daily lives with Parkinson's, but also that aid in treatment options and having discussions with healthcare providers, so that you can make sure that you're treating all the symptoms of Parkinson's that you may be experiencing, not necessarily just the motor ones, which tends to be where we focus most of our attention. So today, if you've joined one of these before, you know how this works. I'm going to be turning this over to our presenter. She's going to present during that time. If you would like to submit questions, you can submit your questions through the Q&A feature, which is normally found at the bottom of your screen. And I will be going through those questions while Dr. Marsh is presenting, and then Dr. Marsh and I will come back and hopefully have time to wrap up those questions. I will say that because of the topic, please make sure that the questions you're asking are more general. Dr. Marsh will not be able to answer very specific personal questions related to mental health issues. So just kind of that, a little bit of that disclaimer. And you can submit those questions at any time, but we will be getting to them at the end of the session. Okay, so today it is my pleasure to introduce to you Dr. Laura Marsh. She's a geriatric neuropsychiatrist. Her clinical experience and expertise has focused on recognition and treatment of psychiatric disturbances in individuals with Parkinson's disease. Dr. Marsh is very internationally known as an expert in this field. She's also a member of our medical advisory board and she is the director of the mental health service line at the Michael E. DeBakey Veterans Affairs Medical Center here at the medical center here in Houston. So, Dr. Marsh, welcome. Thank you for joining
Thank
us
you.
today. I'm going to turn this over so that you can get started on this, and then I will see you on the other side of your presentation with questions people have submitted.
Thank you very much. It's a pleasure to be here and pleasure to have everyone listening in today to celebrate Mental Health Awareness Month. It's great to have a chance to talk with you about this topic. I'll be focusing on depression and anxiety, but also cover some things that can sometimes go along with that. So let's just first start with talking about what is our mental health. And Mental Health Awareness Month is recognized by the World Health Organization. And how do we define what that is? It is our emotional, psychological, social well being. It's thinking, feeling, and acting, and in particular, how we handle stress. Because some people will say, "Oh, I'm so stressed." Well, we all have stress, but it's really how you handle it, and that's where your mental health really gets in that balance. And in that context of other issues, how do we relate to others, make our choices? How do we function with all of the other things that go along with our health? So, mental health is just a component of our overall health. It's not something separate. I always like to refer people back to, Descartes when he said, the mind and the body distinction, were they separate? No, they haven't resolved that. Since then, we know the mental health and physical health go together. And mental health is not simply the absence of an infirmity. I have patients and know many people who can have all kinds of infirmities, but their mental health is actually quite good in terms of their emotional, psychological, social well-being. So lots of things go into identifying or forming or underlying one's mental health status. But I think what's most important is, as a world, as a society, as a community, and on our own, is to what can we do to promote, protect, and restore mental health if it is compromised. It's a vital concern. Truly, it's a vital concern, and I love that you all are including that in your the work of the Houston Area Parkinson Society. And I know it's important for patients with Parkinson's, and it doesn't always get discussed. As Catherine said, the motor issues can take precedence. So what I'll be doing is talking about various ways that mental health issues are related to the overall course of Parkinson's and to the motor function, because Parkinson's is a very dynamic condition, as we know, moving all the time, but also over the course of time. There are changes, and so what's happening in 2020 is not necessarily what's happening in 2025, and you need to understand that things change, and what becomes absolutely important to address is not the same in other times. What are the common mental health conditions, and then what are some things you can do to manage mental health issues and optimize your well-being, or even the people who you care about with you. So I think it's important to remember that when Parkinson's disease was first described, that mental health symptoms were not recognized as a part of Parkinson's, and you see this in Parkinson's original description. The senses and the intellect were not injured, and so it's not surprising that still there is this emphasis on the motor features, but it has become quite apparent to everyone over time that these features do are part and parcel of Parkinson's, and we'll see that they're often present even before Parkinson's is diagnosed. What I was told, and this is one of the advantages of where we are now with Parkinson's, is that one of the reasons that people didn't know that people with Parkinson's had other cognitive problems or mental health issues is not just because it wasn't something that people paid attention to, but there were so many other debilitating features of Parkinson's before we have the current treatments that we have. So that if you couldn't move, you weren't really talking. People didn't know what was going on in the mental state of patients. So I think it's so much better now that we have the ability to, the more we are able to treat and address these motor symptoms of motor aspects of Parkinson's, the more we've become aware of, oh wait, there's this whole other world, this whole mental well-being part that we need to pay attention to. One of the cool things about this particular slide that I just want to say is that for many years we had only images of Parkinson's that showed these very old men, old, and I think that and they were colorless actually, but now we have new pictures of what it's like to be have Parkinson's, and we have this picture of a young woman who's having some foot dystonia as her sort of initial symptoms of Parkinson's disease, and we have an older man with his difficulty walking, his hunched posture, showing the tremor here. So, what do we get with Parkinson's? It's classic motor triad. You've heard this many times: tremor, usually at rest, but not everyone with Parkinson's has a tremor. It can be rigidity, and that's what you're seeing somewhat with her dystonia, and then the slowness of movement, bradykinesia or inability to move, the akinesia or freezing of gait that people describe. And in order to have the diagnosis of Parkinson's, you have to have two of those three, and they begin on one side of the body and they progress over time. And that's one way that you distinguish Parkinson's from other Parkinsonian type conditions. Um, you also have a gait disturbance, which can be present early on. That even before someone knows that they have the diagnosis, someone will say, I've noticed that you're kind of dragging your leg, or the foot turning in as you see in this picture. And then there's the problem start hesitation or freezing, where you have trouble moving forward and initiating that gait, or fascination, where you initiate and then you get faster and faster as you go along. And these are pretty classic. Then over time, there's loss of writing reflexes, unsteadiness, imbalance. Again, I know that people here have Parkinson's, and so they probably are familiar with many of these symptoms. How do those focus into? That's our, that is how you define Parkinson's. It's how you what you look for when you're diagnosing. But the traditional view, that classic view of Parkinson's, isn't consistent exactly with the experience of Parkinson's. So the extent of motor signs is not always consistent with the degree of disability. How much, even if you have impairments, doesn't that isn't always the same as what someone is not able to do. So impairment is what I observe as a clinician. Disability is what you experience in life. And even people who have a lot of disability don't even have the same degree of distress or quality of life. So, what is the secret sauce in that? How do we understand that? And so let's think about this. Um, what we have in Parkinson's is, in many cases, up to half, the depression will, on average, precede the diagnosis of Parkinson's disease by on the basis of its motor symptoms by 4 to 6 years. And anxiety symptoms, they often can coincide with PD onset, but they can also be present up to 20 years before the onset of motor signs. And it can be associated now with the eventual development of Parkinson's. And so there have been a number of studies, and I'm just quoting one of them, where they did this follow up of 35,000 men, and they were showing that those who had high anxiety or were using medicines that we call anxiolytics that reduce anxiety, those people had an increased relative risk of Parkinson's. And this is something we've seen again and again. So it's, if you already have depression, anxiety before you have the onset of Parkinson's, you can't say, "Oh, I'm depressed and anxious because I have Parkinson's," if you don't know you have it. So it's kind of, those are the kinds of things that tell us this is part of the disorder or the brain changes that are occurring in Parkinson's. It's not a reaction to the condition itself. And this is some data that I developed when I was in Baltimore, following a longitudinal cohort of individuals with Parkinson's. They came from the community. They were taking part in a longitudinal study of Parkinson's. We called it the Mood PD study, or Methods of Optimal Depression Detection in Parkinson's. And the red here are people who have a diagnosis of major depression before they have the diagnosis of Parkinson's disease. And the blue is people who had that after. Not everyone in the cohort had this, but of those people who had major depression, 46% of them had the diagnosis before the onset. And you can see it increases in that, 5 to 10 years before the rates. This is frequency, the number of patients with that, and this is obviously the course of time, and with zero being the time when the Parkinson's was actually diagnosed. So I think that's, again, it's supporting that idea that the Parkinson's is associated fundamentally and neuropathologically with changes in the brain that not only address movement, but they address mood regulation. And we'll talk a little bit more about why that is. But let's look at some more evidence to support this. It's not just, how you're reacting, or it's not a character disturbance. This is part and parcel of the condition. So here is data from Yar, who is one of the sort of seminal investigators on Parkinson's disease. You might hear about the Hone and Yar scale, which was used to stage the extent that someone had disability from Parkinson's in terms of their motor symptoms and motor function. When they looked at the people when they first came on with Parkinson's, they described initial symptoms that involved depressive or anxiety phenomena. This is 183 patients, and eight of them had depression, nervousness. They had fatigue or muscle weakness. They had other things that often go along with people who are depressed: muscle pain, cramps and aching, slowness, facial masking, that decreased facial expression. So that these are things that you can see in a mood disorder, but you can also see them in Parkinson. So it can be kind of hard to say, well, which is it? Is it one? Is it the other? Is it both? Um, but again, just underscoring or continuing to emphasize that these aspects of mood and how we present um, uh, overlap with the changes that are occurring with Parkinson's. Um, so what's going on here? Well, we know that the defining feature of Parkinson's disease is the dopamine deficiency, and that is particularly in the substantia nigra, where you have this loss of neurons. And this is a normal brain of someone who doesn't have Parkinson's disease. And the substantia nigra, the black line, is those dark black black substance or substantia nigra, where they have these pigmented neurons, and those neurons are deficient or lost. They die away in the person with Parkinson's, and so you see this faded area of the substantia nigra, and that's reflected by the loss of those pigmented neurons here. And you also have these little fried egg looking kind of things that those are called Lewy bodies. And so you see those two features in that particular part of the brain, the substantia nigra, that you would that is what you need if you're going to get the diagnosis of Parkinson's disease. You've got to have these two features. You can still have other symptoms of Parkinson's disease, but if you don't have these, it's and on the brain tissue, it's not going to be a pathological diagnosis of Parkinson's. So what we did is we look at the various treatment options of Parkinson's, and what that led to was those are dopamine making neurons, and those neurons. So the idea was you basically are replacing dopamine, and you replace it with the levodopa carbidopa, the cinnamate, the various agonists, also these drugs called MAOB inhibitors. There's some other drugs too, the anticholinergics. They don't really work the same way, and they are more often used for tremor. They have other problems with cognition, so I don't like them. But so that's kind of where the basic aspects of Parkinson's, function. But we also, with every medicine, we always know that there are side effects. And when you're working with a drug that is treating a brain disorder, you're at risk, and you're treating a using drugs that impact the brain. You're going to get some potential neuropsychiatric effects. It's just generally called these CNS active or central nervous system active drugs. So, as a geriatric psychiatrist, one of the most consistent things that I do in my practice is basically take medicines away from people because they've been put on medicines that affect their thinking abilities or can affect their mood, etc. So the Parkinson's medicines have the same kind of potential. They also do a lot of good. But you need to know what the risks are. So sometimes you can get these mood changes, you can have psychosis, or you know, hearing things or seeing things that aren't actually there. We can talk a little bit more about that. There can be confusion, and I hope that you've all heard about the risk of disinhibition or gambling and hypersexuality that can occur as a side effect of dopamine agonists in particular. So we along with those medications, we have these various fluctuating effects. So, and we talk about that often being on off symptoms. So, in the motor side effects is over time, and as the Parkinson's is continuing on, like I said, from 2020 to 25, there are changes. And during that time, you won't have the same effect of that medicine because your Parkinson's has also progressed. So, there's a loss of efficacy over time of that medicine. So if you take, two tablets at 10 o'clock, and it usually keeps you going till 5 o'clock, you're not going to get the punch that you got in the beginning, and it's not going to last as long. So you have this end of dose deterioration, and then you get that on off phenomenon. And then in addition to getting that on off, you've kind of end up having a little bit too much dopamine for what your body is used to handling in there at that moment. And then you can get these hyperkinesias or dyskinesias, the extra movements, hyperactive movements of limbs and so forth, as well as that dystonia, where you have that turning of your foot, of the sustained muscle contraction. So those are the two kinds of changes that occur motor wise, on off, and then the dyskinesias. Dyskinesia is the sort of umbrella term. Along with those on off and dyskinesias, you can get changes in particular that are related to off and involve your mood. So you can have off anxiety or off depression. And then sometimes people, when they're in the on state, they have hypomania. It's not just that they're moving and able to do things, but they actually get a little bit more revved up, a little bit. Their mood is better than better, and that can happen. You don't see that as much, but it can happen in some people, and it's important to recognize it because sometimes they can get into a little bit of it can be impairing. So Also, you can see this in during the off states. You can have this slowed thinking, which a patient I think aptly called it cognition. So when you're in the off state, as your medicine wears off or is worn off, your brain just it's like being thinking through concrete or this mental emptiness. And in contrast, when you're on, you can have that mental hyperactivity. So again, these things are really kind of it's the medicine doing all this. It's not the person necessarily, and it's the medicine in the brain in that person. So and that's where it gets complicated because it's not just you; it's also everyone else around you who might actually have an opinion on what you're doing and why and sometimes those opinions are correct or and sometimes they're misinterpretations of what's happening, so that's why we like to talk about this. The other thing that can happen along with this on off is you get these what are called autonomic automatic or autonomic nervous system that controls things like sweating and flushing, dry mouth. And so during those on off states, people can have these changes. And as I said, how people can misinterpret. I had a man come in and tell me, Dr. Marsh, I'm going through menopause. And he was having these flushing sensations, this fatigue, and these sort of hot flashes as he was having. I said, well, actually, it's just your Parkinson's. And so we addressed that. But they can all go together. And this when you have people with palpitations and flushing and so forth, that can, and you're also anxious, it looks just like a panic attack that you would have, if you didn't have Parkinson's and you weren't on those medicines. So, how is all that happening? Well, first, you have to remember, the Parkinson's isn't just in working on that substantia nigra, it's a brain disorder. Every part of the nervous system, including and the rest of the body is affected. So the neuropathology of Parkinson's affects multiple dopamine systems. So we have the one system that's involved in motor function, but we have these other systems, the mesostriatal, the mesolimbic and mesocortical systems that are also involved in things like behaviors, reinforcing behaviors, reward systems, as well as how you think about things. Your executive function is involved in this dorsolateral prefrontal cortex and so forth. So it's not like so you need to remember when you give that dopamine medicine or as you're having you're going to have Parkinson's going to affect differentially these different sections that varying its extents, and that contributes to the different clinical pictures that people have. And not only does the Parkinson's neurodegeneration affect dopamine in these various areas, it also affects non-dopamine neurons. So we have changes in norepinephrine because of the little neuron called the neuronal area called the locus coeruleus, changes in serotonin, and also in acetylcholine. And it doesn't stop there. You can also have some Alzheimer type changes. Not everyone, and different people to different extent. So this is why you get when one person has these symptoms, another person has these other symptoms. But if we know that all these are occurring or have the potential, we can think about what we need to do to treat. And that's why I like treating Parkinson's. I feel like I can focus on, do I need to focus on what the norepinephrine system does because it's involved in more executive function? Do I need to focus more on mood because that would be serotonin or acetylcholine kind of generation because of the because it's involved in memory and so forth. So it gives us a kind of a clearer view as opposed to other kinds of neurological conditions where things aren't as clear cut as they are someone in Parkinson's. So, one last thing about what else is going on, if that wasn't enough. So, these non motor features are particularly associated with all these extranigral, all these parts of the brain that are not the substantia nigra. The brain changes not only in the brain, but also in the rest of the body. So, I mentioned that autonomic or automatic nervous system that can affect things like your blood pressure. It can affect constipation, urinary changes, erectile dysfunction. Back in the brainstem, where you have the locus coeruleus and where you have that midbrain raphe, you're going to get sleep disturbances. You can have changes that involve pain. You get changes when they affect the limbic system and the dopamine. It can involve visual hallucinations. I mentioned the executive function up into the front. You can get some changes with cognition, and then, of course, with mood disturbances. So there's a lot going on, uh, uh, and um, and a lot to think about. But it is still possible to have great well-being and focus on your mental health. It's important to just know that all this is going on and know that you can think about it. So one of the ways it's been really helpful, and I think to understand why we might have individuals presenting 5 to 10 years before they even know they have Parkinson's with mood changes, is because of this hypothesis of how Parkinson's kind of tends to start more peripherally or in these like lower parts of the brain, and that's where you have the norepinephrine, the serotonin, the effects on these other. So constipation is one of the symptoms that people will have way ahead of time before they actually get the diagnosis of Parkinson's or the diagnosis of REM sleep behavior disorder, where you have the dreams that people act out. Again, not everyone has that, but you have these premotor symptoms that are now looked upon as pretty consistently worth looking at in someone, and that we're looking at as people who maybe are at risk for Parkinson's. So I work at the VA, and we are following people who are having these nightmares. Maybe they have nightmares with PTSD, but maybe those nightmares in some cases are actually symptoms of this REM sleep behavior disorder where they're acting out their dreams. They don't have the usual, when someone has a dream sleep, REM sleep, your muscles have what we call atonia, or you're paralyzed, right? You can't move. So when you act out your dreams, you're having a sort of a paroxysmal, uh, 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 you're able to move your limbs when you're really not supposed to, you're supposed to be paralyzed. And so that's what REM happens in REM sleep disorders. You can act out your dreams when normally you shouldn't be able to. And we know that happens in people who've had head injuries. It can happen in people who have other exposures. Um, and you can have a 2.4 increased risk of having Parkinson's later in life if you have that. And so we are tracking those veterans who have those conditions and seeing if this is whether they're at increased risk over time. So eventually, if we can begin to address some of those, identify people who might have Parkinson's earlier on based on other kinds of phenomena, then maybe we can have ways of treating it before they get to the motor conditions, but also treating these non-motor conditions as well. Um, so again, this is just one more way of looking at it and kind of giving all those things, tying up everything I've just said. If you see, here's a person with the motor symptoms beginning at time zero. Over time, you have different kinds of symptoms. So anxiety may be occurring up to 20 years. You've got this progressive loss of your dopamine neurons. It's not until you lose about 80% of them that you start having these motor symptoms. But other things have happened before then that are impacting brain function and what kind of symptoms you have. And then as you go on, other kinds of problems can occur, but anxiety and depression tend to be there earlier on, and they can also occur later. But often it's often present. There's some people who never have any evidence of depression or anxiety. So let's talk about what we have over the course of the disease. So this again is from the Mood PD study. And what we showed was that in this group of people, 250 people with Parkinson's, 80% had, over the course of their life, had at least one kind of psychiatric problem. And a little bit more than about 76% had at least one condition at the time that they were being interviewed. And a little bit over 60% had at least one type of mood disorder. And that's pretty consistent with what you see in other studies. The next highest rate was of anxiety disorders. Um, and then psychosis, where you have the seeing things that aren't there, or potentially having other ideas that are like paranoia, can occur. And then lower on the list was impulse control disorder and substance use disorder. Again, you're looking at the lifetime rates. Again, those are a little bit lower than sort of the average in the general population. And substance use disorders were very uncommon in those individuals in this particular study. Um, we have different rates with the population where I work at the VA of those kinds of conditions, and where that's will be helpful to be understanding that over time. In what are the rates of substance use, and how does that affect whether someone goes on to develop Parkinson's if they have, say, the head injury or the REM sleep behavior disorder. But let's talk about where we are now with people who actually have Parkinson's, and so the biggest concern I always have is when you have an untreated mental health disturbance, it doesn't matter whether you have Parkinson's or any other medical condition. If you have an untreated mental health disturbance, it's going to affect your quality of life, and particularly with depression, it affects that, and it's often a greater negative effect compared to motor symptoms. People have said many times, "I can cope with the Parkinson's as long as I'm not depressed." And what we know is that those that depression can affect your motor, your cognitive deficits, your disability over the course of time. It makes all the other medical and psychiatric conditions worse. Your experience of them, again, if you're feeling depressed and not wanting to do things, you're not going to get out and move, etc. And other kinds of strains, and of course, caregiver distress, and just the general suffering that anyone has if you're feeling like life is not, you can't enjoy things and so forth. And we'll talk about what those symptoms are so you can recognize them. So, I think what's most important is that if you're recognizing depressive disorders, yeah, it's important to distinguish between isolated emotions versus a mood disorder. So we all can have people say, I'm so depressed, but it may be that doesn't mean that you have a mood disorder. A mood disorder has a whole collection of things that go along with it. Just like if you have a little bit of a slow gait or slow walking, that doesn't mean you have Parkinson's. It has to have all the other things, the company it keeps, as some people say. So a mood disorder, there are many types, and they vary in how severe they are, what kind of type they are. But most commonly, we think about major depression, because we know when it's a major depression, we really want to kind of watch that and treat it because it can get, it may resolve on its own, but it seems like with Parkinson's, it's probably a good idea to intervene in some way. So, what do you see with that? Two major features: a depressed or sad mood. So, we all know what being blue is and sad is, or crying, but not always. A lot of times, people will have just decreased interest in things that normally would interest them, or and particular decreased sense of pleasure, decreased joy. I really look for, if I'm when I'm treating someone, I want them to be able to go back out and enjoy the things that they enjoy doing. That tells me that their mood disorder is treated. Because a lot of times people get sort of partially treated. They're not sad, they're not crying anymore, but they're not really enjoying anything. And joy and being interested in things is what I think motivates people. Um, and this is not just, decrease interest because of your Parkinson's. Like, you can't do the woodworking and work with that saw. The person who doesn't have depression will go find something else to do that is also gives them is interesting or gives them pleasure. Whereas a depressed person can't really uh, move forward on that. So what are some other, this is one of the complicating features, as I've mentioned. There's so many of these symptoms between depression and Parkinson's that overlap: appetite, weight changes, sleep changes, motor slowness. It's called retardation in the medical terms, fatigue or loss of energy, and some decreased, thinking abilities. But what do you see in depression that's particularly more, you kind of just say, I'm not going to pay attention to those physical symptoms over there. I really got to, if I'm going to diagnose depression, I'm looking for this sort of agitation that someone has, that sort of angst, or a sense of inordinate or ununderstandable sense of being agitated or upset, feeling worthless. These are really, we all can feel like I didn't make, I didn't do as well as I could have, or I know this is a lot for my family, but fundamentally, people believe that they are worthy of something, and they have some hope, and they don't feel guilty in a way that's what we would call pathological. Um, and so it's important to be able to distinguish that. Um, and then there can also be recurrent thoughts of death or just thinking about one's death. And I often give the example of a patient of mine who would drive home every night and he'd say to his wife, well, when are we going to talk about, what we're going to do when I can't, feed myself anymore? And, he was, he was still working. He was an engineer, and driving. And it really didn't, his wife was kind of like, why are we talking about this? This is not even relevant right now. And let's enjoy what we have today. He was having a lot of this sort of preoccupation with death. And there can also be thoughts about wanting to harm oneself, or just thinking about, or even making attempts. And that becomes an emergency in those situations. Um, so how do you recognize a depressive disorder? You look for the emotional features, not for the motor features. And what you see is that those emotional features are pervasive and persistent most of the time, most every day. So persistent sadness, decreased interest, decreased enjoyment. We call it anhedonia. A pessimism, a hopelessness, having negative thoughts like thinking about, when you won't be able to feed yourself. This inappropriate guilt. Um, and as I said, feeling overwhelmed, even when someone, can do something, they believe, they have this experience of themselves, this negative view of them sense of self, that they can't do things. And a good example of that was a patient who had surgery. He was doing great after the surgery, but he still had a mood disorder that needed to be treated. And he kept calling up the doctor saying, then surgery didn't work. The surgery didn't work. We bring him in. He's like, basically skipping down the hall. His mood disorder was what the problem was. It was his perception of what was happening. It's like looking at the world through mud colored glasses. And while your physical symptoms may be worse, it can be really hard if you're just going to focus on, well, they're slower, they're this, that. You really got to focus on these emotional features. Um, Along with depression, you can often have anxiety. Anxiety can be a feature of depression, very common. It's not an understandable reaction to Parkinson's. Again, I've mentioned before, it can occur before people have the diagnosis of Parkinson, and there's several types. It can occur as part of depression. It can occur as an independent motor condition, excuse me, an independent mood state or disorder. It can also occur secondarily. So, like for example, if someone is having more cognitive problems and you give them, their income tax to do, and their medicine is worn off, they might get anxious about being able to do that because their brain isn't going to be able to process that, and they can feel upset and worried. So I think often I look for what's the role of cognitive deficits or being in that off state when someone is as anxious, and how much is that, where do I need to treat that? So looking at this, there's several types of anxiety. Some are very typical and some are PD specific. So episodic ones are things like panic disorder. I mentioned before, you can have the on off fluctuations that can look just like and you have off anxiety, it can look like a panic disorder. Some people just have panic disorder that comes on in the course of their Parkinson's or before they have Parkinson's, and it's probably related to some of the neurochemical changes in the brain that are occurring then. But the panic disorder isn't all the time. These are sudden onset of these panicky symptoms, that don't really have a basis. It's not caused by something, and then after about 10 to 15 minutes, it goes away. You also have people with situational anxiety, and that's phobias. So, for example, going into public places or being around other people, or social anxiety. When they're home, they're fine. And so that anxiety really only occurs, when they're exposed to that particular kind of problem. And the best example I had was, I learned about Parkinson's from my patients. That's where you really learn about what you're doing. This patient came in to me and he said, well, about 10 years ago, I was in a restroom stall and I suddenly became claustrophobic. He had no reason to, have that. He worked in a cherry picker up on the telephone lines. And so that was when I first sort of began to see patient after patient with Parkinson's. And, they were coming in and telling me about these new onset phobias. As a psychiatrist, phobias typically begin in youth, and not when you're in your 50s. So that was a kind of a sign already that there was something going on in the brain there that was different. Um, Continuous anxiety is what we would call a generalized anxiety, where you kind of worry about what to worry about. Am I going to get to the phone? Am I going to do this? And so you can have that with Parkinson's anyway, but this becomes over the top. It becomes clinically significant. PTSD can also be like that, where you're having sort of a hypervigilance and a anxiety all the time. Um, the PD specific ones are what I mentioned, in particular, this wearing off anxiety and the panic that can occur with that. So you can have panic episodes independent of wearing off, and you can also have panicky episodes that are part of the wearing off. And the difference is you need to know what you're treating, because if it's wearing off anxiety, what you need to do is work on the motor medicine, use smooth out how you're treating that with, with Comtan and other medicines that, or maybe people have DBS, so you don't have those wearing off symptoms, because the DBS can be used to treat on off phenomena. So if you were only treating it as a psychiatric problem, you would never address those wearing off conditions. Um, this is looking just a little bit more at kind of what the rates of those are, and this is several studies again just showing that, that you get these Parkinson specific anxiety disorders. Really is what I want to show. 22% in our sample had these anxiety disorders not otherwise specified, often kind of falling. We couldn't really characterize them according to the usual anxiety diagnoses in the, in the general population that occur. They were really Parkinson specific anxieties. And in Denmark, and excuse me, in the Netherlands, they had about 11%. This is pretty well recognized now that these occur. And I remember having, lots of discussions with my neurology colleagues. They wanted me to treat this psychiatric problem. It's not a psychiatric problem. It is part of their motor fluctuations, and we need to address that before I do anything else to this person. So, how do you tell whether the anxiety is related to the depression, or whether the anxiety is a separate condition? And so, anxiety is interesting, because often what you have to do is you treat it behaviorally, and not so much with medications. Um, uh, the medications can help when it certainly is part of a depression, but a lot anxiety often has to be managed with making some behavioral changes or doing things behaviorally, like breathing, to help reduce your anxiety, things that help all of us when we're anxious. So, what are the distinguishing features in an anxiety disorder in the absence of depression? Being apprehensive, worrying, being at the top of that roller coaster and worrying about what's going to happen, anticipating the negative, not believing that you're negative, but just anticipating, oh, something bad's going to happen. Some of these other things, I'll get back to avoidance, but overly detailed, reacting really strongly to something, and being more worried about it, fearful, etc., ruminating a lot. In addition to the anxiety component of anxiety, where you worry about what to worry about, there's another way that what people do with anxiety, and that's they avoid. The best way to manage something that makes you anxious is to avoid it. And so if you are afraid of going out in public spaces, well, and you ask the patient, well, how are you doing with your anxiety? Oh, I don't have any of it. That was because they haven't left the house. So they avoid going out because it maintains that anxiety. But the more they don't go out, the more you avoid whatever it is that makes you anxious. This is kind of in general, whether you have an anxiety disorder or not. Until you go out and do it, you're not going to get anxious. And you have to kind of work through it. So when you have a phobia of something, you're going to avoid going over bridges or snakes or whatever it is. So if you want to get over that uh, anxiety, that phobia, you have to go confront it. The difference when you have depression, again, is you would have pervasive guilt, sadness, the decreased self worth, all these sort of more, fundamental things about one's self, the morbid thoughts about, what will happen when you can't do X or Y. Apathy is another phenomenon that can occur with depression, but it can also occur independent of depression. It can be an independent disorder that can be very frustrating for families. And often, we want to, if it is part of depression, we want to treat it. Typically, someone who is apathetic doesn't have anxiety. So that's one thing, but you still need to look for the other features of depression, loss of motive, but that are part of what is also an apathy. This loss of motivation, more of an emotional indifference, um, often associated with cognitive changes. And these patients aren't complaining; it's their family members who complain. And so but you have to see the person over time, and of course, you get a good a sense of what's happening over the course of time. Often, person with apathy will be happy to go do things with you if someone else provides that structure, and that's often one of the ways that we treat it. Um, Another phenomenon that occurs in Parkinson's more than it would in just the general population is something called emotionalism or pathological crying. Um, and that can occur in up to 40% of patients. You can see it with certain with depression, where if you're already sad, you're going to cry more readily, and then as your depression gets better, that kind of subsides. But you can also see it with delirium. If you're on certain kinds of medications, benzodiazepines, Xanax or Valium or Ativan, that some people get that they are like when people drink alcohol, maybe they cry more easily. And what you see this with this emotional is, very sudden, heightened, excessive tears, very short lived, and then it goes away. It's often involuntary. It might be occurring like I have patients who every time they would mention their grandchildren and they would have trouble, they'd be embarrassed to like go to their grandson's birthday because they knew that they would start to cry every time they would go to their little grandson and give him a gift, and then they cry, and then that would kind of scare their grandson. So they once they kind of know that this is something that just occurs, and they weren't depressed, they didn't have any other thing to treat, then they, oh, okay, maybe this isn't so bad, it's just something I do. And sometimes we do actually treat that with medications. um, the last is psychosis, and I've mentioned this before. These are hallucinations and delusions. So hallucination is when you see something or hear something when there isn't actually something there. You can also smell or taste, and or feel something on your skin. But typically in Parkinson's, the most that people have are these visual hallucinations, and they talk about what were called minor hallucinations, this sense of presence that people have. It's not really a true hallucination because you're not seeing something, but it's a sense that someone is there. When they actually see something, it's a brief vision in their peripheral field, like something just walks by the door. Or they can have these sort of sensory distortions. The hallucinations are more like they would actually see a little girl sitting on the end of their bed. I always love the example. I woke up and there was this girl sitting in the chair right next to my bed, and I knew she was a Republican. I don't know what that meant, but it was just seemed to be a kind of funny thing to wake up and see. Um, and then there was so these are we call these hallucinations or minor hallucinations, but we really are also we look for all of them, because even the presence of some of these earlier, we can maybe adjust medicines or look at, whether you're getting enough sleep, what are some precipitants of that. Um, the Delusions are when you have a fixed false belief about something that's not actually, there's no basis for it, like whether you may think that you're seated at the right hand of God, or that you are that. And more common in Parkinson's are these that we often see these what's called you believe that your family member is having an affair or cheating on you, and that can be very distressing in Parkinson's. These tend to occur later in Parkinson's, over up to 40%. They can increase with certain kinds of medicines, with age, with progression of Parkinson's, and it can be a real challenge to manage that. So, but that's why it's important to know about it. I've already kind of mentioned some of these, and I didn't forgot about the next slide. Sorry about that. But these are, again, most common are visual. When you ask people in detail, you get a lot more information. And so there were, in this particular sample, up to 76% had some kind of illusion that maybe someone was stealing, that they weren't in their own house, or that their spouse was an imposter. These kinds of things. Again, if someone is saying these things, it's not that they're this needs to be brought to the attention of your clinicians. And these can also be occurring as part of a mood disorder. So a major depressive disorder might have. I had a patient who believed that people were stealing from her, and that she was various things are going to happen to her. We treated her depression, and at the end of her depression, she still would see like birds flying in the air, but she didn't have any of these other delusional ideas. So really, it's important to know when those might be part of that. Last, I want to go over these medication related mood symptoms, syndrome. So early morning off, called an emo state. Someone wakes up and they're in a really low mood, gets better, or had anxiety. That gets better as the day goes on. And this particular Dr. Nuremberg has a whole practice that focuses on dopamine agonist withdrawal syndrome, or DAWS, where people coming off of the dopamine agonist can have extreme panic attacks, and they have to really be taken off. They can have, along with that, a lot of depression, all these other symptoms, flushing, all those panicky type symptoms that occur along with that. And then they can have drug cravings with it. It's a real thing. It's a condition that we treat. If you're seeing that, it's something to call attention to with the clinician. And then I've talked about these on-off motor and non-motor fluctuations. And this is just an example of that, where what's so interesting as a clinician is if you see someone at noon, they're doing well. Their medicines, this is, you take your medicine at 6 a.m. in the morning, it's working well, but you got a little bit of dyskinesias or wiggling a little bit when you're at 8:30, and then you wear off and kind of go through the day like this, but you're doing okay. But when we see you at 3 o'clock, you're down in the dumps, you're sad and anxious. And so the goal is to kind of smooth this out so that if it's truly related to just the medication dosing, we need to address that first. So this is again what I will often ask people to do is track, make a little piece of paper, and then six, seven, eight, nine, and then you kind of track, how's my motor symptoms, how my mood symptoms, what's going on with my medicine, did I forget to take my medicine, and that can make all that worse as well. So I've mentioned these already, the non-motor fluctuations, the drenching sweats, the hot sensations, those kinds of things that can happen, that can look like a panic attack, but they can also just happen in Parkinson's in the absence of panic attacks. And um, the slowed thinking, and then the sensory or other some physical symptoms that can occur. To move on, last are these impulse control and behavior disorders, pathological gambling, hypersexuality, shopping, punding, which is where you do a behavior again and again and again, like maybe putting books in and out of the shelves. Or someone I had was, she would get to the around the oven and she'd start to really work on getting all that little crud that gets right on the edge of the stove. And her husband said, well, I think we got that. But that was what she did. And then we kind of adjusted her medicines, and then she stopped doing that. So that was good. And then there can be the misuse of the drug. So let's move on to what we do for treatment. So whether you work at the VA or don't work at the VA, um, the optimal treatment for mental health is that they only work when you actually pursue them. So it's good to know about them, but you also got to go for it. And often we want them to be targeted to you, and collaborative. And often it involves, maybe you see the occupational therapist, or the you see a therapist to talk about things, but you also see someone who's prescribing a medicine, or doing any number of things. So I'll talk about kind of what my approach is, and how what you can do to support that. So best is by giving a little example. This is a guy, 70-year-old. He was a veteran. He also had alcohol problems. He had major depression, and he had new onset panic attacks. So he did a 24-hour diary, hourly recording when he was up. He looked at his mood, his anxiety, his sleep, his Parkinson's, motor, his meds, and what the circumstances are. And we adjusted his meds. We gave him, and he actually was a DBS candidate ultimately. We educated him about how to make sure you're taking those meds on time, being, having as much, healthy lifestyle. And we did some behavioral interventions. He was having these anxiety attacks, and we did breathing and distraction, was very helpful to him. In fact, that's often one of the favorite, it's my favorite intervention, is breathing. It's free, no side effects. It works. And you've always got it with you. Some mindfulness training could be something else. Rehab therapies for where he's having trouble with doing things. If he's having less function, maybe there's some adaptations that he can do, or maybe physical therapy would help strengthen him so he doesn't have to worry about the risk of falls in the way that he has been. Um, or speech therapy to help improve his speech. Very specific psychotherapies. Cognitive behavior therapy is widely used now for anxiety and depression and Parkinson's. We also have some specific PTSD therapies. And then it's only when I've kind of done those things that I might, if those aren't really working, then I go to some other treatments, like medicines or others. So the little acronym that I use, and I use it with all my patients, and I say, "Is your treatment a mess?" And if your treatment's not the full mess, then you kind of feel like a mess. So every time, if you're feeling like a hot mess, you go, "Wait a minute, which of the parts of the mess are not being addressed right now? Am I not optimal?" So one is your medications. Have you optimized those? Do they need to be adjusted? You need to get rid of some of them. Like, are you taking medicines that actually affect those neurons that are already you're already losing those neurons? You're losing your cholinergic neurons. You're losing your serotonin neurons. Get rid of those because they're probably not helping. They're making things worse. Education, things like this, learning about what these look like. Because if you know what something is and you're talking about it, then you can do something about it. If you don't talk about it, you're not probably not going to be able to do something about it. Making some lifestyle interventions, evaluating the home, learning what you can do at home to make life safer, things that HAPS does a lot with folks. Skills are really important. And they have to be practiced, and they go so people often think, "I just give me the pill. It's so much easier." But without the skills going along with it, you're not going to be able to have those sustained benefits. So that's why I love rehabilitative therapies, PTOT, speech, recreational therapy, kinesiotherapy. And I love it when people get evaluations that kind of show them what their strengths are and what also and where they're a little bit on need, not that you can improve it, but how you can use your strengths to compensate. And last is the social support, which the HAPS has. They've got all these things. They work on. They give you the ESS, and you just have to make sure you're working with your doctor on the M. But you've got all the support. These things help you get through. As HAP says, no one will experience Parkinson's alone. So those things make a huge difference in just getting along, getting the education, etc. So, as I said, is your treatment a mess? I kind of add safety, falls, harm to self or others. Again, we always work on, work with the VA. I pay attention to suicidal ideation, suicide behaviors, and this can happen in Parkinson's. And so we want you to know if that we have gun locks and other kinds of ways that we can help to mitigate those concerns. And you could bring that up with HAPS folks, and I'm happy to help in any way that I can. Um, and that can happen more if someone is having paranoia or unusual beliefs about someone. Um, what about other things? Some safety planning that people can do, looking at both safety for falls, safety for suicide prevention. We often talk about time and distance, and we can go more of that if you have additional questions. But I didn't update this. It should say 988 on there. Is the number. If there is, it does. You don't have to be a veteran. Anyone who has a mental health crisis, whether you have Parkinson's or not, you can call 988, and there's someone on the phone to talk with you, and that's a national number. So last, I just communication with your clinical team. Mental health, as I said, like any other medical condition, impacts your overall physical health and well-being. And our clinicians are not going to realize that the mental health issues are important or relevant if you don't bring them up. Again, if it's just like in psychotherapy or in marital therapy, if you don't talk about it, you can't do anything about it. And if you don't appear any different than usual to them, they're not going to know that you might have these concerns. So I bring those concerns up first if your mental health concerns are important to you. And even if your clinician may not be the right person to handle it, they will invariably want to make sure that you get some help and they get some insight into what's going on. Call if you experience changes in your mental health. Don't wait for an appointment weeks to months. Often there's someone's had a medication side effect or a urinary tract infection that really is a quick fix. So call your clinician up and they can say, "Oh yeah, I see we just started this," or XYZ, and then they can make that better. Bring an informant or someone to provide collateral information, and that's also support to you to all appointments. I love informants because they can give me a perspective on uh, what they have observed, and then we can come up with a consensus over what's going on. Our best practices involve regular screening for mental health symptoms and find out what screening tools your clinical team use. And if that tool isn't picking up on your problem, well, maybe there's a different tool and you can bring that up, with HAPS and they can help you figure out something. Um, Summary, just again to end this, mental health conditions and symptoms occur over the course of Parkinson's, including before Parkinson's is diagnosed, and they relate to the underlying Parkinson's disease itself, the brain changes in Parkinson's. Each has distinguishing features. Someone can have more than one, but what's important, whether you have one or many, they're treatable. I really enjoy working with Parkinson's and treating patients because I can get them better. We can't get rid of that movement disorder, but overall, but often when we treat depression, we try to treat it to remission, and so it's very rewarding to work with people in these psychiatric problems. The behavioral treatments, as I mentioned, for anxiety are also very treatable. So, with that and all that extent of information, I'm ready to take questions.
Okay, fantastic. And we do have questions. Hang on. Oops, I'm not going to do that. I'm going to see if I can stop sharing your screen so that we can get.
Oh, well, I will stop the share. Yeah, there we go.
All right. So a couple questions, and I will say just to kind of preface, as those of you continue putting your questions in the Q&A part, which I appreciate, just know that Dr. Marsh is not going. This is a complicated issue to answer to answer some questions, and so I know a couple of people have put questions in that have been maybe a little too specific, a little too personal, but don't have enough detail, I think, for Dr. Marsh to be able to answer, because there's a lot of, well, that's going to depend on a lot more information. So I'm not going to go through those questions, but I am going to go through the more general questions that we've had. All right. So one, in terms of percentage, can you go back over kind of what percentage of individuals with Parkinson's experience anxiety, but also will experience depression?
So, what I have observed in others, anxiety in many cases tends to be a more chronic condition. This is in the general population as well as in Parkinson's. So, when someone has an anxiety disorder, and not just anxiety that we understand. So, we're really talking about what I would say clinically significant anxiety, not just worrying, gosh, am I going to cross the street and get across there? So, um, uh, because we want you to be anxious about some things. It's good. But this would be, so people who have anxiety conditions, they tend to have a higher risk of developing a depressive disorder anyway. And depressive disorders are kind of more episodic. They occur in, they have a course, they begin and they get worse. And even on their own, they can get better over time. And then what you can see is that sometimes then people end up kind of with a chronic condition if it's untreated. So, in general, depression alone is more common than anxiety in Parkinson's. So, then that data that I showed is about 60% versus 40% with some kind of anxiety disorder. And about probably, anxiety can be a feature of a depressive disorder, but it's not necessarily an anxiety disorder along with it. What I tend to see are people have kind of a pre-existing anxiety disorder, and then they get depression on top of it, as opposed to depression and then they have an anxiety disorder that evolves. That's, there are exceptions, but often there'll be the person who kind of is worrying about what to worry about often, and then they end up superimposed upon that, they get the mood disorder. And so in that case, just to kind of answer the rest of that is, well, what do you treat? Well, I would treat probably the depression with, an antidepressant medication if that's, what the person was agreeable to, if it weren't too severe. If it's still mild to moderate, you can treat this with behavioral treatments. And we know that the cognitive behavior therapies are very effective for that. So, and then continuing on with the anxiety, but they're still having persistent symptoms. I would encourage taking an antidepressant medication because again, it's part of the brain change. It's developing in the context of these brain changes that are occurring, and we can just kind of replace some of those neurotransmitters that aren't working with some of the medications. So, and it's very effective.
Yeah. Okay, and what about anxiety episodes? Do you find, or just anxiety in general, if a person is dealing with anxiety, do you find that that anxiety increases as Parkinson's progresses, or does it stay relatively stable? And I mean, it's persistent, but it's not necessarily worse. What are your
Yes. Um, Great question. Again, everyone's a little different, but in general, I think usually what people have, when they're earlier in the course of their Parkinson's, they might have different kind of coping strategies for it. So it kind of depends. Sometimes what you get is someone who they tend to be a worrier, but they cope with it a little bit better because they have a little bit more sort of personal resources. And as Parkinson's progresses, say you're having more cognitive problems, um, and which is and then you're say you've always been the person who paid the bills. This is when I first started taking care of Parkinson's, we didn't have things like Quicken. So someone would, or automatic bill pay, which is really reduced, or GPS, things that you could always find people's problems so much easier, because things weren't automated. But the kinds of things, anything that kind of makes the brain have to work a little bit harder, and if they already have an anxiety problem, it's the circumstance. So if there's a progression of some cognitive changes, that can make that anxiety worse if they're already kind of a worrier. And so that's why I always like to look at what are the circumstances when that person's getting anxious. Is it because they're at the nadir of their medicine, right? They're in an off state. Is it because they're being asked to talk to 5 people at once and they would be do much better one-on-one because their voice is soft? Or is it that, they actually are having a panic attack that has nothing to do with any of these things and we need to treat that? So it's real, everything has to be kind of parsed out. But definitely as someone goes along, the anxiety could occur in other kinds of contexts. And then if you're having more trouble problem solving, and say you're not able to get to the restroom on your own, then there can be this agitation and anxiety, and then humiliation that could occur with that. So some of that's very circumstantial as well. Um, so I try to, if I can identify, and then just sort of try to batten down the hatches. So those kinds of situations, so if they're going to pay the bills, do it when you're on. Do it when there's only one person around, etc.
right? Okay. What about experiencing anxiety? If you're experiencing anxiety and rumination around the same time every day, is that indicative of a medication issue, or would that be, is that just how some people present?
That is s- both. It could be, and again, this is where the timing goes. When are you taking your medicines on time? Are you taking them when you're supposed to? Or your medicine's working? I've had many patients I had a patient who would call me every day at 10:15, and she was having a panic attack, and so we could predict it. And what we did with her was we came up with some behavioral strategies, so she wouldn't be calling my office every day, and literally every day. And then we came up with breathing exercises that she would do. And so you do see this where, whatever it is in that person's body rhythms, their medicines, etc., you have to be able to understand kind of what their predicament is like. But yes, I've seen many patients who have once a day, and then they have like a fluke. They have 3 days, nothing happens, and they have an event at 3 o'clock instead of 10 o'clock, and they think, okay, it's all better now. Or but then they would worry, oh my God, this is going to happen all during the day. So again, you see where that worrying, you can worry about what to worry about, and the more worried you get, the worse it gets. So sometimes knowing that yes, you can see it every day at 10 o'clock or once a day. And again, what we did in that case was they would start to do something, a task, like at 9:30 or quarter of 10. And this person was like to do woodworking, and was like they would do sanding. Anything that was kind of repetitive is what worked. For another person would sing, or they go and they ride on a stationary bicycle, breathing. Um, and seeing if that works. But you've got to kind of rule out all the other things, because you don't want to be doing something. I mean, it's probably not bad to breathe or ride on the bicycle, but it may not do everything you need.
Okay, got it. What are your thoughts on alternative treatment approaches to depression? So this person kind of specifically said either like herbal supplements or things like acupuncture or acupressure. Have you seen those things help alleviate? This was more specific to the question about depression.
Yes. Well, so for a while there were the medicines like St. John's wort that was, people. Oh, I'm only going to take St. John's wort. I'm not going to take regular antidepressants. But St. John's wort, it was also depending on which kind you were taking, it was destroying people's liver. These are still medications. Many medications were developed using compounds in nature. So I don't really regard them as that alternative. If that supplement is psychoactive, it's a drug, and I like to know what people are taking. And sometimes they can be taking too much of what could be a good thing in a small amount. If it's not effective and you're still having depression, it probably isn't. Why bother? And sometimes those things can be very expensive. Things like acupressure, it can make you feel better, but it may not make you well. And when I'm treating depression, I want you to get well. I want you to be going back to being able to enjoy yourself, not feeling, just not feeling neutral, but get rid of the sadness, get rid of the depression, but start to have interest, start to be able to do things. And if you're not getting to that point, we need to think about what else would. Acupressure or acupuncture typically are not going to be definitive treatments. But if you have mild to moderate depression and doing things that make you feel better, and that's kind of a win-win, and you're doing, eating healthily, taking your medicines on time, et cetera, and healthy relationships, et cetera, getting the support, full mess, the right medicines, whether it's a supplement, they're still medicines when you're taking those. So I guess that answers that.
Interesting. Yeah, I just read an article a couple days ago about this idea that, you still have to be very careful about supplements. And a lot of times we don't think about that because we think of them as being natural, and so people have been overdoing supplements and causing all kinds of problems with liver. Specifically, this was related to liver. But so okay. If you've been on this person, so I'm just kind of paraphrasing and putting together a couple of questions that came in that were relatively similar. Um, People who've been on an antidepressant for a number of years, it had been working, now doesn't seem to be working as well. So is it possible that if you changed to different one, can you change to a different antidepressant, or is it possible that that will help, or is this is are you or I think people are a little worried about, treatment resistant depression, but
Right.
I'll have you elaborate on that.
Yeah, sometimes, there's a kind of a definition of treatment resistance. Sometimes it's that, what the medicine worked. Maybe you need a higher dose. Maybe you need, maybe you have other symptoms. Making sure that what you're seeing is, not like some other conditions. Like if you have untreated sleep apnea, maybe that antidepressant is not going to work as well if you don't get that apnea treated. So again, all these, that's the M of the mess. Making sure that you kind of ruled out all these other things. And this is not just for Parkinson's; it's for anyone. Because depression, we all have a mental state, and so it's so easy for everyone to interpret things as being all part of one thing or not the other. But our mental state comes out of that body. But yeah, we change antidepressants all the time based on what the people's symptoms are. We might augment them. We look for thyroid problems. We also use other treatments. Like sometimes we use transcranial magnetic stimulation. Seems to be very helpful for Parkinson's. If someone has really severe Parkinson's, we might use electroconvulsive therapy, which is very effective for the motor symptoms of Parkinson's as well as for mood. And there are some patients who medicines didn't work very well, but ECT, they could get it every 2 months and they were hunky dory. And so, it's a matter of working with what works. But not giving up, because there's always, something, and being very clear. I'm treating this anhedonia. I'm treating the guilt that I feel, and or maybe there's anxiety as a component to it. So again, trying to parse out what we're seeing and what's happening. But we change medicines all the time.
Okay. And if you decide to go on an antidepressant, does that mean that you have to stay on it forever?
Great question. And also I want to, so one is never stop them suddenly. First of all, if you are on one, because people can have a withdrawal syndrome that is worse than the depression. And it can look like panic attacks. It can look like agitation, and you can just get worse. So I do everything very slowly as a geriatric psychiatrist. I do things probably slowly than more people would want, but I like to know that, because there's always so many other things going on in someone's life, that if you just, you go up slowly and you go down slowly, you can kind of control for all the other stuff that happens in life. So one is, if say I treat someone for their depression, they're better, they're back to, they're like great, they're doing well, they're doing everything they want to do, and it's a year later, you're stable, their mood is good, they're happy when they want to be happy, and they're unhappy when something's sad. Um, and then I'll say, okay, you're taking, duloxetine, which is good for mood, good for pain, etc. And say they're taking 60 milligrams. And I really hate taking this. And I would then go, there's a 20 milligram, there's a 30 milligram, go down to 40 milligrams a day and see what happens. Sometimes people, again, we already kind of know that Parkinson's is a progressive degenerative disorder. So we don't know what happens when most people stop. Some people have been able to stop and they never get another episode of depression. Some people need to stay on it and we go back up. But what you don't want to do is just kind of go off of it and then have another episode of depression. Who needs that? If you know what the symptoms are of your depression, they're likely going to start to rear their head as you stay off that medicine. And so then you can go, oh, here it's coming again. I really am waking up every day and I kind of feel like life is not worth living. You don't need to have that. That is your brain tricking you, um, etc. So I would say that it is an enigma to me why people will get treatment with for a cancer and they take all kinds of medicines that completely their medicines can kill you, right? Those cancer medicines. Our medicines keep you alive and make you want to live, and we have a hardest time getting people to accept them. It's interesting, but it's the reality. So I encourage you to keep taking them.
All right. And you and I have had this conversation more times than we can count about, the lack of available psychiatrists, who can step in and help the population, either because they're not taking Medicare or because some of them get a little concerned about Parkinson's and the Parkinson's medications, and kind of not wanting to create more problems, even when that may not necessarily be reality. So, what's your best advice when talking to people who are experiencing this? Because we also know that often we're clinicians are not super proactive in saying, "Hey, this may also affect your mental health. It may not just be limited to to motor symptoms and to constipation and sleep issues." And so, if you've got a neurologist who says, "Yeah, this is kind of outside of my scope," but you can't find a psychiatrist, w- h- what's your advice to people on that?
So, one, if you're a veteran, let us know, because one, we may be able to help you get into being seen here at the VA. There are, you should have a primary care doctor, and most primary care doctors should have sort of a network that they work with, but they also are. It's a very common thing to treat depression or anxiety in a primary care practice. So that's often the first stop for most people. In fact, most people don't want to go see a psychiatrist, and if they can get 50 to 90% of people treated for these conditions in primary care, that's great, because some people don't need an expert. Um, so one, I would go back to, if your neurologist says that's not in my area. One, you've got information. You want to be tracking your moods. You want to be then go to your primary care doctor, but also go to your Parkinson's doctor. Say, well, here's some people. Maybe you could call and ask them a question, or get them to go to some of the meetings that we have, that HAPS might have for clinicians, and they can learn a little bit more about it. You can always educate them just like they educate you. And I actually, back in '96, with a colleague of mine, Matthew Menzer, we wrote a book called Psychiatric Issues in Parkinson's Disease, and we really wanted the book to be for patients, but the book publishing company wouldn't let it be a patient book. So we wrote the book so that patients could throw the book at their doctors when they weren't getting what they want. But that was a long time ago. But some of the ideas are still there. The basic treatment of depression has not changed since then. The kind of concepts that I've gone over are still what you follow. Your primary care doctor can usually work with you. There often are therapists in the community that are available. And I think again, think about that mess approach, and then if you can get those other things, if it's just the medicine and all these other naughty medicines are taken away, chances are you're going to do pretty well. Again, look for I know that you'll be able to listen to the recording. Get track those symptoms, and there are a lot of mood trackers online that you can also use. um, I see there's a question here that I actually want to answer, the one on panic attacks.
Yeah. That was gonna be that's the final question. So I'm just gonna read the question since you're reading it too, is does a panic attack always have the element or demonstration of anxiety? Do some with panic attack symptoms display or act calm while describing all the symptoms?
Yeah. That is such a vexing situation because the person is sitting there and there are, not everyone, this idea of the squeaky wheel gets the grease. And it's even harder for a person with Parkinson's because they don't necessarily have the facial expression. So they can be very sad or they can be very anxious, but they still look the same, right? And so is it that they're calm? But there is something that I think is often, yes, the answer is yes. You don't have to be falling apart to be having a panic attack. There are many people who have panic attacks while they're driving. Fortunately, they just keep driving, but they are feeling very tense inside. Some people have an internal tremor, which is something that wasn't recognized. It's now recognized. You can have internal tremor, and not have an external tremor, and along with that, they can get this anxiety. So it can be have a wearing off, but it's only like with an internal tremor, and maybe there's panic attack symptoms along with that, or maybe it's not a panic attack, it's just a wearing off. Yes. So the answer, and when I have, as a psychiatrist, there are, you start with believing what people tell you, what their experience, just like anyone, if you tell me something, people don't really want to be uncomfortable and make up symptoms that they don't have. They prefer not to have them at all. So generally, when they're reporting something, it's that they don't understand it, or they are uncomfortable with it, and they want you to know about it. So it can be very frustrating when someone says, well, you don't look like you're anxious, and then that just makes people more anxious. Or the other one is that when the doctor says, well, you don't have anything to be anxious about, and I've taught doctors to say, well, that is how you make your patient more anxious. Because if they're not anxious because they're supposed to be, they're anxious just because they are. And so but it is frustrating if you're the family member, or even if you're the patient, and you don't have to be, you can be depressed and suicidal, but you don't have to be acting on those things. And so, but you can tell your clinician, just because I look okay doesn't mean I am. And I want you to know I really am feeling badly. And that's probably the way to get past that.
Yeah. Well, we know that anxiety and depression, impulse control issues, all of these things can be quite disabling, and I mean disabling in kind of the immobilizing way, in that it
Mhm.
interferes with your daily life, and somehow we have to, we're kind of back to where we start with everything, which is to educate individuals and family members so that they feel knowledgeable and then empowered to go and have these conversations, because that's really the way that things get done. I mean, we can't, there are so many symptoms and there are lots of treatment options. And so, the way to get things done for the individual is for the individual to be able to say, okay, here are the realms that I need help with. And we'd like to be able to rely on clinicians to do that, but there's just not always enough time, and they can't fix something that they don't know about. And we still have a lot of stigma associated with, mental health issues, with treatment. I have one neurologist who says we're just going to call it serotonin replacement therapy, like we call it
Yeah.
dopamine. replacement therapy. And if we think about things as treating symptoms, we should be thinking about things as treating symptoms, no matter what those symptoms are. So, but it's, it's still a topic we don't know enough about, and we certainly don't talk enough about it. So I thank you for coming today and for being a part of this conversation and for helping educate all of us. So thank you, Dr. Marsh, for your time, and thank all of you for joining us today and for the questions that you submitted. They were great. There will be a recording. We did, Dr. Marsh said we could record this, so we have, and we will get that on our YouTube channel as soon as we can. And so if you need to rewatch, you're certainly welcome to do that. But we will let everyone get back to their Friday and their weekend, and hope to see many of you soon in person at our upcoming summer events. Again, Dr. Marsh, thanks so much for your time.
Thank you, everybody. Bye bye.
Bye-bye.